Joan French, is it?
That's right, yes.
Hello, I'm Dr. Galloway. I'm one of the doctors. I'm from the day team. You came in last night, I gather, actually, but...
Yes, I did, yes.
So, I've come to see you about what's been done so far and what we need to do
they've not done anything so far.
Okay.
What do you mean, what have they done to me?
Okay, so can you tell me about what happened when you came in, actually? Just to tell me...
Well, there was a lot of waiting around, I'll tell you that. I came in last night, down to casualty. I was there for hours. They said I'd have a scan. They said the scan had happened very quickly, and it didn't. It was 6 hours waiting for a scan. I thought you were supposed to be in casualty for longer than 4 hours. I was there for 6 hours before they even got me to a ward after the scan. And then when I come on the ward, have you seen the state of this place? I mean, I'd be ashamed if it was my house. I got into my bed and there were marks on my pillow. There were dirty marks on that pillowcase. I mean, it's really awful. No wonder people get ill in hospital. And then I couldn't sleep because the lady next door to me was muttering all night. She was restless. They wouldn't give her anything to keep her quiet. So I got no sleep whatsoever, on top of the headache that I had. And all the weight I had, I was really tired from being out there. And then I'm in here. Does anyone ever get any rest in these places? Ever? I mean, because it seems to be people walking up and down. I couldn't get any sleep. Then they brought breakfast this morning. Well, that's a laugh, isn't it? That's a laugh, the breakfast in here. Cold coffee, cold toast. I mean, what sort of treatment is that for people? I thought you're supposed to help people get better.
Oh, okay. I'm really sorry. It sounds like you've had a horrific night.
Well, I just want to go home. I've just had enough. I just want to get out of here.
What happened to bring you up to casualty? What was it that you've had this headache?
I had a headache. It was a really bad headache. It happened very suddenly, and that was, they gave me some painkillers last night. I think it was morphine or something. They did a scan, and this morning they tell me it's normal. So why am I here?
Let's talk about what happened. This is a conversation I think probably should have happened last night. I'm really sorry it didn't. When the doctors saw you, and I think looking over your notes, you described this very sudden onset headache, and that was very severe. I mean, severe enough for you to come to emergency.
Yeah, it was really bad. It was like being hit around the back of the head with a tennis racket. It was that bad.
The description you've given is very suspicious for what's called a subarachnoid hemorrhage. This is a condition where a small blood vessel in the brain can leak or burst. And obviously the brain is what controls all your bodily functions, and things that go wrong in the brain can potentially be catastrophic. They're also potentially very amenable to treatment if we catch them early.
But they said my scan was normal. I mean, why couldn't they have said that last night when they had the scan? Surely it's immediately visible. They could have let me go home then, and I would have been able to get some sleep this morning.
So let me go back to the condition. Is when this happens, if a blood vessel does leak, what can sometimes happen is there can be a warning small bleed before someone has a larger bleed. The small bleeds don't always show up on a scan. In fact, about 10% of people who have this condition have a normal scan. And it's the people who have these little small warning bleeds, if you like, where we can really make a difference. And quite often, those are the people where the headache goes away again quite quickly, or whether
I'm fine now.
Yeah, I mean that's actually it's a very good sign, but actually it still makes me very worried that you could have had a very small subarachnoid hemorrhage. And if we can pick up the small ones, we can sometimes treat them and prevent someone having a major hemorrhage, which could be, like I said, catastrophic.
Well, why didn't somebody talk me through this before? I mean, they tell me nothing. When they took the scan, they must have seen on there what was happening, and nobody said anything about what they saw on the scan. Nobody's told me anything since. Consultant comes round this morning, part of his ward round or whatever, just throws at me this thing that he might need some injection in my back. And not so much as a proper explanation. I mean, it doesn't look like he's been long out of medical school. I mean, to make him a consultant at that age. I mean, what age do they become consultants these days?
We're getting younger and younger.
You're still wet behind the ears.
I don't have an answer. I can try and fob you off for a bit longer, but I think the honest answer is that sometimes things aren't done perfectly in hospital. I hope the quality of care in terms of the decisions we make are right, but we do sometimes fall down in our communication to people. And clearly this has happened to you, and I'm really sorry about this. It's far from ideal. In terms of the scan, quite often what happens, I mean, I can read a CT scan and spot something obvious, but actually interpreting the scans isn't done by the sort of the physicians on the ward, it's done by the radiologists. And so quite often if a scan's done at 4 in the morning, even though you have the scan done at 4, the radiologist may be reviewing it they get sent electronically to their homes. They may not review it till 4:30. They may spend half an hour looking at it and trying to identify very small or subtle changes. Maybe 5:30 by the time the report comes through to us. The report will go through to a junior doctor who will then pass it up the ladder. And if there's 10 patients waiting to be seen, you can see how sometimes these things...
Well, why don't they just explain that to you? I mean, I'm not unreasonable.
Yeah.
If somebody would actually take the trouble to say all this.
It's unfortunately what tends to happen is normal results. We tend to be much worse at communicating to people. It's the abnormal results that we have to act on, that we go and run and say, this has shown up. But that's not the way it should be. And I think, and I certainly think when these sorts of things happen, where clearly the system's not worked for you, you need to let not just me know, but you actually need to let the management know. And I can give you the information for the patient advice.
I do feel like I've been messed about quite a bit.
I think it's really important we get feedback, because if we, it's by people like you saying where it's gone wrong that we can start to change.
Right. Yeah. Well, I think I will, because I just felt as though I was totally brushed off last night. And this morning when the consultant came round, I mean, I just...
Yeah, I'm really sorry about that. That aside, I think there is still the question of where we go from here, because going back to sort of your health, the scan's very good news, don't get me wrong, it's a normal scan, but like I said, about 10% of people who have a subarachnoid hemorrhage, these small bleeds, they can have a normal scan. And the only way to detect it is if we take a sample of the fluid that flows around the brain, what's called the CSF, and we can test that to see if there's any blood in it. And that's a very, very specific test and very accurate. So if that's clear, we know it's all clear. Obviously we can't stick a needle into the brain though, because altogether wrong, but what we can do is we can put a needle into the base of the spine, because the fluid travels all the way down the spine. It's much safer at the base of the spine as well, because we can do it below the level of the spinal cord.
Right.
Take some fluid out and analyse it in a lab.
Is it dangerous to do this? I mean, because there's nerves there.
I mean, I think all procedures have a potential risk, and the risks with a lumbar puncture, I think this has to be taken in context. The risk of a subarachnoid hemorrhage is much more serious, and so I'm sure we should be doing this procedure. I think the risks are definitely worth the benefit of knowing, because if you did have a subarachnoid hemorrhage, we can treat it.
Would that stop me from having another one?
This wouldn't, but if we find there's one there, we can investigate it further with... I'll come back to that in a minute. Let me tell you about the procedure first. The risks to the procedure are... Well, probably the most important risk I warn people about is that it's what we call a blind procedure, in that we're putting a needle between the bones in your spine to reach this CSF, this fluid. And although I can feel the bones through the skin, it's actually quite a long way and the needle has to go, and I'm slightly guessing. So sometimes it's a difficult procedure to do and we don't succeed. We can fail. And if that happened, I'd have to ask one of my colleagues in the radiology department to do an X-ray and do it under X-ray guidance. That said,
you might have to have it done twice.
Yes, you might have to have it done twice. That said, most times that doesn't happen, but I warn people about that beforehand.
Right. Well, I mean, it's better to know things.
Yeah. The other risks I tend to warn people about before lumbar puncture, firstly, that because it's like any procedure where we pop a needle through the skin, there's a small chance we can introduce infection. I'll try and minimise the chance of that by cleaning it all. I'm going to wear gloves and gowns and do it in a very sterile fashion, but it's important you're aware, because should you develop pain around the site, you should let us know and we'd give you antibiotics to treat that.
So you would be doing the procedure, would you?
I'll be doing the procedure.
Right, and you're very experienced at this, are you?
I've done these procedures before plenty of times, yes. The other risk is that when I pop the needle in and take some fluid out, I can sometimes leave a small hole in the sac that keeps the fluid in place. So it's called the dura, but it's like a sort of a skin within which all the fluid sits. If that happens, it can sometimes cause a small leak of fluid. This can sometimes result in you having a really bad headache. Now I know this is what we're doing this to investigate, but this is a different sort of headache. We can try and prevent this, but I'm going to use a very small needle. I'm also, when I do it, going to do it with you lying flat. I'm going to keep you lying flat for 4 hours afterwards. And when I've done it, the other thing is, if this did happen, if you did get a headache afterwards, we can treat it very easily. We can do a little patch to patch up the hole. It's a very straightforward procedure to do, but as long as you know that if you were to have a bad headache after this lumbar puncture, you'd need to let us know and we can do that.
Right, okay.
Again, the vast majority of people we do lumbar punctures on have none of these complications. That's about the procedure itself. The procedure I'll do, if you agree to it, I'll do that this morning. It'll take about 6 hours to get the results, 4 to 6 hours, because it's a matter of doing some quite complicated tests in the lab. Once I've got the results, if they're normal, we'll get you home later today. If they're abnormal, and they suggest you may have had a small subarachnoid hemorrhage, I'd need to speak to the neurosurgical team at Hope. Not because they're about to do an operation, but because they're the people that are experts in managing this. When you said, could we treat it, they're the people I'd get in touch with. Sometimes they can do very clever scans, and they can see exactly where this bleed has come from. Right. And following that scan, they can sometimes actually pinch off that bleeding vessel by doing what's called an angiogram. But I think I don't want to go down the line of explaining all that until we know that that's definitely needed. But I think that you should understand the first step is do the lumbar puncture. Once we get the results of that, we take it from there.
But even though my headache's cleared up, you think that's
I think
important?
Particularly because your headache's cleared up, because it could be that this was one of these warning bleeds, that we can intervene and prevent something more serious happening.
Okay, well, why didn't the consultant talk to me about it before?
Again, I can only apologise. I think it's not an excuse, but sort of having done many of these ward rounds, the consultant has a list of 35 people he has to see from the night before, and he stands at the end of the bed and says, you need to do this, this and this. And sometimes when it's very busy, that's all they've got time for. It's far from ideal. But like I said, I'll give you the patient advice liaison service information, and I mean I think that's not something to do now while you're in hospital, but once this is sorted, put it down on paper, speak to them, and make sure this all gets fed back to us in detail.
So, but you keep me informed of everything
I
as
will
it goes.
definitely come back to you. So I'll come back to do this procedure in a little while. It'll be about in the next hour, and then once I've done it, I'll come back to you with results as soon as I have them, and that'll be about 6 hours after I've done the procedure. Will I have any
back pain afterwards or anything like that?
Don't normally have back pain. It's sometimes a little uncomfortable, but I put anaesthetic in to numb the back when I'm doing it, and that sometimes aches a bit as it wears off. If it does, we can give you painkillers. Okay.
Okay. Yeah.
Okay. I can give you some written information about this procedure as well to read before I do it.
Yes.
And I'll let you read through that before we do it.
Yeah, I'd like to do that.
And I'll come back. I'll also I'll ask you to sign a consent form just so that you say that I've been through this with you and you've read the leaflet. Have you got any other questions or anything?
No, I'll read the leaflet. If anything comes out of that, I will ask you. Okay. I just feel like, I just wanted to get over it and gone home now.
I'm really sorry. Let's do it right from now. I'm really sorry.
Please.
Okay. Right. Thank you. Right. So this is a discussion relating to the communication skills with Joan French, and this was a consent for a lumbar puncture, but with the complication that she had a somewhat delayed admission to the hospital and long waits overnight, and was quite dissatisfied with the care she had. So I think hopefully you will have a relatively straightforward case in the exam, but if you do come across someone who's very angry, then it's very important to be able to approach this sensibly. First of all, I think it's very sensible to let people get out their anger. Don't try and stop them talking about it. If someone has something in the consultation that they're very angry about, allow them to talk about it. At the same time, I think as well as sort of acknowledging their anger, saying that it's quite reasonable for them to be angry, be cautious, don't try and apportion blame to your colleagues, although equally you're not there to defend them. And it's also very reasonable to apologise for things. I'm very sorry that you had such a sort of a terrible night, that the delays were so long, that no one told you the results. And that's very different from saying, Dr. So-and-so should have told you this. It's sort of finding a balance between the two. You'll note that I offered her access to the Patient Advice Liaison Service, the PAL service, and it's very important to know they exist, and that that is the formal channel if a patient has a complaint that they should be passed through. The second part of the consultation was about discussing actually the need for a lumbar puncture, about explaining why it was important. So the clinical sort of situation of a sentinel headache, someone has a headache, they get better, but then a week later they present with a completed stroke, and why it's so important to pick up those people. Someone has a normal CT, that doesn't mean, even if the headache's gone, they go home without an LP. They always need an LP. I went through the LP procedure, talked about the risks and about the benefits, and you'll note I also said I would come back with a consent form to go through a written consent procedure and offer written information. I think that's something more and more that we should be erring towards in medical practice. I suspect a lot of us do LPs and don't go anywhere near a written consent form, but I think for the PACES exam, that's probably what we should be doing a central line, doing a chest drain, prescribing chemotherapy. We should be putting this down on a written consent form to go as a documentation in the notes about the procedure.